welcome again to another edition of the Osteopathic Lyceum podcast. I'm going to take some time to specifically speak to fascia. Now, really myofascia or the myofascial system. It is very rare that when you actually dig into research or available information on fascia that you see it as just fascia or reported as just fascia. More often than not, you're seeing reports on the myofascial system. So what I'm going to do is give a general overview of what the myofascial system would be comprised of, as well as show how to identify resources and take a look at what you might be interested to know about fascia, while also providing the caveat that whatever fascia you're thinking about, unless you're working surgically, it's very unlikely that anything meaningful is going to meaningfully change your behavior as a hands-on practitioner. So obviously, most of what I put out is aimed primarily at hands-on practitioners, such that whatever it is that I'm putting out may not necessarily apply to other healthcare fields as much. But any interest in fascia, you're probably really talking about the myofascial system, and it isn't meaningfully going to change your behavior with respect to the patient, and that is contingent on the fact that you are working from the external environment of observation. You're outside the patient. You can't see inside. You can't accurately identify the fascia. You don't know the particular presentation that that individual has with respect to that particular fascia. You're working from the outside, so you're having a hard time interpreting, but you can find gross movement dysfunction. So if you focus on movement, you'll be accurate to your findings, you'll be accurate to the patient. If you go any layer deeper in consideration, you are making mistakes, whether knowingly or unknowingly. So what I'm going to do is I'm going to share my screen. So the first thing I want to show is what's called StatPearls. So StatPearls is more or less a very large online textbook. Usually, if you look up something anatomical, what you're going to find is something that points you to PubMed. And usually the anatomical resource on PubMed is contained within StatPearls. StatPearls is more or less a very, very large textbook that is curated by relative experts or likely experts. I mean, I'm sure you could squeeze through this and find some that may not be as well written as others. However, they are consistent and pretty good resources on any piece of anatomy. Now, they're not necessarily going to, and also some physiology. They're not going to teach you everything about a piece of anatomy. They're not going to talk about the wide variety of variability between individuals necessarily, but it does a pretty good job. So just to scroll so you see, right? So first, based on naming conventions and how things are set up, it's going to start with numbers, right? So 17 hydroxylase deficiency, 21 hydroxylase deficiency, 24-hour urine collection. So this is very much essentially a collected medical resource or healthcare resource. Go down a little further, abdominal aortic aneurysm imaging, abdominal aortic aneurysm rupture, on and on and on. So what I'm going to do is I'm going to bring up the search function by pushing Control F. I'm going to have to move this. Is it going to work? There we go. Now it works. So when I hit Control F, I already have pre-typed the term fascia. So when we go and look at fascia, what I'm going to do is just click through these so that you see what's available here. So within the pelvic region, there is a description of Scarpa's fascia, right? There is a different name for Scarpa's fascia that can be identified, but Scarpa's fascia is the most common name. You're going to find the anterolateral abdominal wall fascia, right? So above that, you've got the anterolateral abdominal wall. Then you have the fascia, or the description of the fascia in there. Camper's fascia. You have lower limb and pelvis and lower limb foot fascia, pelvis and lower limb fascia lata, so the invaginating fascia that surrounds the entirety of the thigh, or not surrounds the entirety of the thigh, but it is the description of where all the fascias connect to on some level. So the fascia lata is also called the IT band or the iliotibial band or iliotibial tract. And all of the thigh fascias in some way or another connect to it as it dives from superficial to deep. All right, you have, again, the pelvic fascia, so anatomy, bony pelvis and lower limb, pelvic fascia, tensor fascia lata muscle, right? A general overview of fascia, so you could look at that should you be interested. Fascial layers, cervical neck fascia, temporoparietal fascia, superficial musculoaponeurotic fascia system, right? So again, lots of different stuff in here. Now, when we get, I'm going to go a little further. There's physiology of fascia, temporoparietal fascial flap, so that's more surgical. Ultrasound guided fascia iliac compartment block. So that, again, that's more procedure based. And then we get a little further down. So I'm going to go back to where it said myofascial pain. So if we go to myofascial pain, I would click on it and it would go over to the next thing that I have in line here. This is by Bruno. This is curated or written by Bruno Berdoni, Kevin Suganamar, Matthew Valacalo. I may very well be mispronouncing some of those names, but what this is, so within StatPros, it's going to provide activities for healthcare practitioners. So if you were interested, you can go ahead and read through this and go through that activity. But what I want to do is just provide or go through the intro really quickly. Please excuse me. Yeah, so the fascial system. So I'm going to read from this, and you're going to see some interchangeable terms as I look at something else, but the myofascial system or the fascial system, here it says the fascial system, and I'll read now. Fascial system consists of solid muscles, bone, cartilage, and adipose tissue, and liquid blood and lymph components, the myofascial system. So you see, right, you've got it happening right there. I'm going to just move my screen here or move my video box. So it goes from fascial system to myofascial system. And so maybe I'm misreading that because as I'm reading through, and this is what's going to happen sometimes. So as you're looking through information, you're going to find that information, and then you're going to think it works one way, and then upon reflection, you'll identify that it works slightly different. The fascial system, so I'll reread it just so this becomes more clear as to what happened in my head. Fascial system consists of solid muscles, bone, cartilage, and adipose tissue, and liquid blood lymph components. The myofascial system comprises contractile muscle and connective tissue. The latter creates the shape of muscle, penetrates the muscle, orients the nerve and vascular endings. It has a thickening at the end of the contractile district that forms the insertions and origins of muscle on the bone, thereby transmitting movement from the muscles to the bones to which they are attached within the myofascial system. The other components include the nervous, vascular, and lymphatic systems. Nervous tissue, axon, and various afferents, and the resulting terminations are enclosed in multiple layers of fascia. Different tissues work in harmony to make up the myofascial continuum. The fascia integrates all the muscles contained within into an interconnected network, and it would be incorrect to consider a muscular district as a separate entity. There might be a mild typo there. No, and I don't necessarily need to continue here for the purpose of discussing fascia with the specifics of myofascial pain. What I will do, where was it? Oh, anyways, there was something there that, or I thought there was something there that's escaping me. So that's not the point. The point is that we get a general overview of the fascial system. It is continuous. It is generally connective tissue. So some people will be speaking about muscle. Some people will be speaking about blood and lymph and nerves and whatnot. What I will say is that neurons, or your classic nerve that you're going to identify anatomically through dissection, has a lot of connective tissue in it, right? The vascular system is made up of varying forms of connective tissue. So you've got this histologically differentiating tissue that can be described at any point. So you can stop at any point and give it a name, like campers or scarpas if you're in the pelvic region and the lower limb. So you can talk about the names of those fascia. But what is more useful conceptually is to understand that it's all continuous, and that these things, while histologically different, so a muscle is histologically different than an artery, and an artery is histologically different than a vein, and a vein is histologically different than a nerve, and a nerve is histologically different than a lymphatic vessel. They all share a very similar characteristics, and they all do have connections. So their histologies do connect, which is why fascia can be interesting if you're talking about orderly movement of nerves, arteries, veins, and lymphatics, as well as the ability of muscles to slide over one another, the ability of muscles to transmit force, connect to bone. So as a general thing, muscle will blend into tendon as connective tissue. Tendon will blend into periosteum as connective tissue. Periosteum will send fibers deep into the matrix of bone. So tendons don't really attach to bones directly. They attach to periosteum, which is the shrink wrap around the bone, such that there is force transmission into the matrix of the bone as a histological projection of the periosteum. So you, again, get this continuous system that can have different names at different points, has different presentations at different points, but it's really one. Now, because it really is one, especially in a living system, you can get into lots of discussions that are based on thinking. They are not necessarily based on observing. In that they are based on thinking, they would epistemologically, or as a theory of knowledge, be constructivist primarily. They are not necessarily positivist. So constructivism indicates that the truth would be dependent on the individual, the previous experience of the individual, and the environment of observation. Positivism would suggest that there is a singular truth that can be identified with appropriate experimentation, and the challenge is the variability between observers. So you essentially attempt to create the view from nowhere. Now, when you attempt to create the view from nowhere, one of the problems you run into is you minimize the variability to some degree in how you report that. So you report the stable features, and you often leave out the unstable features. But what you will find in a lot of more empirical science is that they do talk about the unstable features. And if they haven't, then that's a great place to go and do some research. A lot of anatomical papers that you read that are more recent, what they will say is something along the lines of there is not much information on the common morphology or common morphological differences of fill in the blank muscle. So there is common variability in this. That common variability is one of the reasons that we use a heuristic-based approach to figure out how to assess and treat patients, because that heuristic is a method to suggest or to generate possible solutions, because the generation through an algorithmic process of a definite solution does not properly line up with the normal known variability between people and even within a person. That matters to the discussion around fascia on account of the fact that while there is appropriately described fascia, it's going to be somewhat variable. It's going to be variable from one side of a patient to the other. So the fascia lata on one leg, so on the left leg versus on the right leg, is going to have some variability, right? So we are going to have some challenges with it, or at least with trusting a description and having that guide our behavior, because we know there's variability. So just because we find a thing that is ascribed to the fascia lata doesn't mean that's the case. We have an empirical problem in that we can't observe the fascia lata appropriately. We can only observe proxies for it. So because we have this long united chain of tissues that are histologically different yet connected, we can have things that, let me move this so that you can see what we're looking at here. I'm going to move my video box again. Hopefully that works. So I'm going to zoom into this a little bit more and pull it over here. So you will get a paper. This is from 2023. I don't know exactly when it was published, but it's from 2023. No, I lied. This is from 2020. This is from Bruno Bordoni, who is a PhD, doctor of physiotherapy, I believe DPT, and I believe that would translate appropriately to doctor of physiotherapy in Italy, because I believe he works in Italy. It actually says it here, Physical Medicine and Rehabilitation Foundation Don Carlo Gnocchi, Milan, Italy. And then this is also written by Thomas Myers. Now, Thomas Myers is well known for his work on anatomy trains. He does a lot of dissection. So he's well known for being very interested in fascia and the myofascial system. And he has done some very interesting dissection, which creates continuity between things because of how it has been dissected. The challenge with that is that how you dissect something ends up generating what you are able to observe. And the reason that some people dissect differently is because common dissection methods do throw away a lot of tissue or they disrupt a lot of tissue. So the ability to observe it is poor or different. So if you dissect in a new way, then you have a new observation. The problem with that is it's not contiguous with a living specimen. Studying living specimens has problems. But Bordoni and Myers worked together in 2020 to produce a review of theoretical fascial models, biotensegrity, fascia integrity, and myofascial chains. And I don't need to do actually the abstract is going to do quite a bit here. I'm going to do the abstract and then I'll go down to the conclusion. The abstract, the fascial tissue includes solid and liquid fascia, body fluids such as blood and lymph. The fascia's nomenclature is a subject of debate in the academic world as it is classified starting from different scientific perspectives. This disagreement is not a break, but it is in reality the real wealth of research, the multidisciplinarity of thought and knowledge that leads into a deeper understanding of the topic. Well, the topic of discussion is the fascial model to conceptualize the human body, that is, how the fascial tissue fits into the living. Currently, there are some models, biotensegrity, fascia integrity, and myofascial chains. Biotensegrity is a mechanical model which takes into consideration the solid fascia. Fascia integrity considers the solid and liquid fascia, and the liquid fascia. Myofascial chains converge attention to movement and transmission of force in the muscle continuum. The article is a reflection on fascial models and how these are theoretical scientific visions that need to be further investigated. So something to note about anatomy trains and Myers. Myers will move from unnamed fascia to a tendon to a bone. So we'll go through, say, the tibialis anterior to the patellar ligament to the quadriceps tendon to a particular quadriceps muscle, go up through the thigh, and then continue on vertically through the body to create, say, the superficial anterior line. So it'll go all the way up, but it will change from, say, a strict fascial tissue to a bony tissue to a ligament to a tendon to a muscle again to a fascia, so on and so forth, because what that is doing to help you understand the claims that would be made in anatomy trains broadly is that connective tissue is continuous regardless of its specific histology. So you can trace it almost any way you like. You could trace from, say, a particular muscle to a particular fascia to a particular neurovascular bundle. So you could do the SCM to the carotid body, carotid sinus, the vagus nerve, the internal jugular. So you could do that. The name of the specific fascia is currently escaping me, but the SCM deep to it. So you could go from skin, or you could say go from the mastoid process to the clavicle, include all of that and call that a fascial chain, right? And that any movement of the clavicle, then because it's all connected and continuous in varying histology, you could then start to make the argument about movement of the scapula or movement of the shoulder girdle really is movement of the vagus nerve, or tension on and off the vagus nerve, or tension on and off the carotid body. Now, in doing that, you're doing that because you can observe that these things are continuous and connected with varying histology. You're not observing whether or not this movement of the shoulder girdle, generally speaking, does anything measurable or identifiable or observable to the vagus nerve or to the carotid body. You're making the assumption that because they're connected, well, they must be connected, they must impact one another. And maybe sometimes they do, and maybe sometimes they don't. But the vast majority of the work done on fascia is really just noting and observing that these things are connected. It's not necessarily attempting to identify whether or not that connection ends up having an impact. If you can even identify from the outside in a hands-on practice whether or not the restriction is in the fascia, and if it is, that it does do something to an internal process. Again, we're bound by, unfortunately, that external environment of observation. All right, I'm going to go. So you get some interesting pictures, right? So you get the thoracolumbar fascia that I'm pointing to in white on the back. You get the fascia lata, or the iliotibial tract or iliotibial band on the lateral side. The glute max attaches to it. right? The TFL, or the tension fascia lata. You can see in a cross section of any muscle, you'll get bone. So I believe that's tibia and that's fibula. You're going to get varying muscles. You get the neurovascular bundle. I might be wrong about that upper third of the leg. That's a cross section of the thigh, right? So you'll get into the varying septums, right? So these septums, so you've got the skin, the adipose tissue. So you can see that although this is a drawing, there is a continuity to all of these things. They're going to attach from skin to adipose tissue to ligament to tendon to bone to muscle to vasculature, right? These are continuous, but they do have different histologies, right? One of the ones that people really seem to be very interested in is like the sagittal sinus. Oh, what is wrong with me? The venous sinuses, the sagittal, and so the venous sinuses and the varying invaginations of dura, right? So because there's connective tissue here, any movement of the brain or any movement of the neck or any movement of the head or any movement of the bones within the head can then be assumed to put tension on and off of these things. Now, whether or not that's the case hasn't necessarily been appropriately observed, but it can be assumed. If you just look at anatomy, you think these are connected and you think these will have meaningful impacts. The next step is to take that prediction and test it appropriately, which we're really not quite at least in osteopathy and many other professions. Where we go, we got to get down here. All right, so this is an example. I'll zoom out so you can see this. This is the front line, the deep front line. So this is one of Meyer's lines. So you see it's going from the foot through the leg, through the thigh, through the abdomen, the diaphragm, the lungs, the trachea, the tongue. So you're getting all the way through. So all these varying connective tissues, different histology, but continuous. So if you cut it the right way, you can pull this out of a person. This is all in continuity in a living person, but this is possible to do. So that's why it's important that you understand that the insights that Myers is going to have are going to be based on how Myers dissects, right? So you can see some of that there. I'm going to come down here a little further. The conclusions. So the conclusions, instead of sticking specifically with what the writers or the authors are talking about through the whole thing and going through that deeply, I want to point to the conclusion. The conclusion here, and I will read: the models that try to represent the human body through the fascial continuum, biotensegrity, fascia integrity, and myofascial chains are based on valid concepts, but which currently do not include all the nuances of the living. For this reason, we must remember that they are theoretical representations that need further steps forward to better understand the fascia and to understand the fascial behavior in the presence of subjective anatomical anomalies and in the presence of pathologies local and systemic. We need to know how the histology of fascia changes based on age, based on the daily intake of drugs, and how these variables can affect the adaptation of the myofascial continuum. So talking about normal variability, talking about the presence of pathologies, talking about what it is like in the living. So the valid concept, I'm going to stop the share here. The valid concept that they're pointing to is the observation of continuity. It is fair and honest and accurate to claim that all of these tissues are continuous with one another with varying changes of histology. But that doesn't mean anything other than what you've observed. So if you observe that something is continuous, but it changes its density, it changes its type, it changes whether or not it's more fluid or it's more solid or it's more contractile or less contractile or things of that nature, it can be continuous, but the only observation you can take from that is that it is continuous. At the moment, based on how those models were built, they were just observational. They were not necessarily trying to figure out whether or not something else was happening. So a break in the continuity, what does that mean? Has not been figured out yet. So when I say that the current models, and to understand that Thomas Myers was critiquing Thomas Myers in the conclusion I just read, that it may be a valid concept, but it doesn't necessarily predict anything as far as health state. There's a lot that we don't know about how fascial or any other connective tissue system in continuity impacts health. yet. We can start asking those questions. Now, that is why I am happy to note that fascia is a thing, it is continuous, but for the hands-on practitioner of any form, it doesn't really mean that you need to change how you behave, right? Because how you behave is going to be dictated by your motion findings. Your motion findings are found from the outside of the patient, looking in. Any information you get about asymmetrical motion is a proxy at best for what's going on internally. It's not what is going on internally. So another way to say that is the map is not the terrain. So a map describes terrain, but it isn't the terrain itself. So the movement describes restriction, but it isn't the restriction. The restriction is something deeper that you have to make some assumptions about. But the more assumptions you make as to the specificity, the specific tissue, the more problems you're going to run into because you just can't observe it. So fascia is, depending on who you're talking to, we could be talking about all connective tissue, which would include fluids, because blood is considered a connective tissue, and I believe lymph is properly considered a connective tissue. But if it isn't properly considered a connective tissue in and of itself, it is then encased in connective tissue. Nerves are connective tissue. These are all connective tissue. So when you say myofascia or the myofascial system, or you talk about fascia in hands-on therapy, you would be well within the limits of proper discussion to limit the discussion. So usually the more instructive thing to do when talking about myofascial release or fascial treatment systems is actually to talk about muscles. Muscles are, at the moment, better understood. They're not perfectly understood, but they're better understood than the individual pieces of fascia in continuity that wrap in between all muscles, or that wrap all muscles into a complete unit as well as separate units, allowing for sliding and allowing for transmission of force. So talking about muscles makes more sense based on the knowledge base that is currently available. Talking about fascia makes less sense because of the knowledge base currently available. The broader scale that allows for meaningful intervention as far as the information that's currently available in total is to say that if you are working from the outside of the patient, you identify a movement problem, then you've identified a movement problem that indicates some underlying thing is going on. Then if you have different ways to interface with the movement, right, based on things like the barrier concept, based on things like mechanoreception, based on things. So the barrier concept will include mechanoreception, it will include pain receptors, it will include a lot of things. And whether or not you go into restriction or soften the soft tissues, you've got some choices to make. And when the movement changes, you know that you were correct to the movement, but you don't know if you were correct to the nerve, if you were correct to the muscle, if you were correct to the fascia. You can't figure that out. So my hesitancy with talking about and deeply naming specific fascias is primarily because it doesn't change behavior. So what if I'm over the region that should be Camper's fascia, or I'm over the region that should be Scarpa's fascia? I can't detect it appropriately from the outside. I don't even know if that person's Camper's or Scarpa's fascia is a uniform density within them, right? I don't, or if it's uniform in its presentation bilaterally. These are things that are not necessarily knowable unless you do unfortunately invasive assays, which isn't valuable for hands-on therapy. So hands-on therapy is about movement. I can tell whatever story I want post hoc, but I have to admit that I'm probably wrong. So the key takeaway from fascia is that even the people that are interested in fascia, like Myers, admit that as a viewpoint, it's a valid observation, but it doesn't necessarily tell you much about health state. Now, Myers may have some very, very powerful hands-on therapeutic interventions, but they may not actually relate to fascia the way that one would want, right? So the work can be good. However, the claims have problems once you go deeper than the observation of movement for a hands-on practitioner. So hopefully that taught you a little bit more about fascia and the broad state of fascial research and the broad state of the claims and what kind of use they're going to provide you. So again, hopefully that was useful, and I look forward to talking to you again soon.